Lemierre syndrome is a septic internal jugular vein thrombophlebitis, otherwise known as post-anginal sepsis. Lemierre syndrome arises a complication of deep neck infections. The condition is commonly seen in IV drug user which are utilizing cervical injection at the site of drug use, and it is characterized by formation of infectious thrombus within the internal jugular vein. This leads to septic emboli that may precipitate metastatic foci of infection in the lungs, joint, skin, soft tissue, and other organs. Any deep neck space can lead to Lemierre syndrome. These deep neck spaces divide into three main parts. Spaces that spanning the entire neck are superficial, retropharyngeal, danger, prevertebral, and visceral neck spaces. Suprahead spaces are submandibular, parapharyngeal, parotid, peritonsillar, masticatory, and temporal spaces, and infrahead space pretracheal. Any infection, then these spaces can lead to Lemierre syndrome. So these are the spaces which lead to Lemierre syndrome, and it is a complication of these space infections. Patients with this condition present with spiking fever, rigors, and other signs and symptoms of systemic sepsis after mainly upper respiratory tract infection. The diagnosis is based on history of infection of upper aerodigestive tract with presence of bacteremia in the blood, with evidence of internal jugular vein thrombosis by CT scan, MRI, or USG. And there are clinical signs of septic emboli such as metastatic abscess of lungs and joint. So on these ground we can diagnose this Lemierre syndrome. Fusobacterium necrophorum is usual causative agent of Lemierre syndrome, although other bacteria are Klebsiella pneumoniae and diabetic patient mainly, Prevotella species, Staphylococcus, Streptococcus, Enterococcus species, and Proteus mirabilis are the common causative agent. Fusobacterium necrophorum is typical member of oropharyngeal flora, usually sensitive to regimen consisting of penicillin, metronidazole, and clindamycin. Management of Lemierre syndrome mainly consists of IV penicillin, metronidazole, and clindamycin. Anticoagulation as part of treatment is still controversial, and there is no consistent evidence supporting use of anticoagulation. Surgical thrombectomy or internal jugular vein ligation is usually reserved for patients who have persistent septic emboli after appropriate IV antibiotic therapy.